Good morning, everyone. We are so excited to be with you this morning. We have gathered an esteemed panel of some excellent thought leaders and colleagues to kick off this whole person care event this week. We love starting with a panel because, as you guys know, a lot of times the panel conversations are filled with some of the most robust information we're able to learn at conferences like this. So we're going to spend the next 40 minutes or so really talking pragmatically about how to integrate data from across multiple silos: pop health, clinical quality, behavioral health, social determinants of health, into real clinical care models, care coordinations in order to break down silos. Now, as I say those words out loud, all of you guys who are here hoping to learn more about whole person approaches to care know exactly how critical those 4 or 5 pieces are: the data, the social determinants, the behavioral health, and the mental health. That's kind of where we're going to focus, is really standing in the gap in the next 45 minutes. So let's start with a little bit of introductions, so you know a little bit about who you're listening to. I'll start with myself, and then I'm going to hand it around the horn so you guys can get a little flavor for who we are and what our lens is in this space. As our lovely Strategic Solutions friends probably mentioned, my name is Melissa Smith. I am the Executive Vice President of Consulting Professional Services at HealthMine. We consult in the government programs and provider space, generally in regulated markets where we're trying to chase the intersect of whole person care as measured by the triple aim, things like star ratings, quality withholds, HEDIS. Those are the sorts of things that we help our clients chase. I've got a long history in the space. I've been doing this kind of work since 2014. So if I ask some questions that feel like plants, it's because I'm a good consultant and love to pick and probe. And I've also sat in the whole person care space. I spent about 10 years at Cigna HealthSpring doing this in the plan space, about 10 years at Vanderbilt doing it in the provider space. So I really understand what we're trying to solve for as we think about silos. So with that, I will say I think I'm the least esteemed of my colleagues today. Probably we really want to hear more about their backgrounds and their histories. So Steve, let me hand it off to you as our esteemed physician on the panel. If you could give a little bit of background of who you are, where you're coming from, and a little bit of your lens on whole person care, and then we'll go to Lucy, and then let's go to Emily, and then we'll jump right in if that works for you guys.
Great. Thanks so much, Melissa. Delighted to be here with you all this morning. Stephen Peskin. I'm a general internist by clinical training, got interested in kind of medical policy management more after residency, and have the last 10 years executive medical director for population health transformation at Horizon, and we'll get into what that means in a little bit. Also associate clinical professor in the Department of Medicine at Rutgers, and I'm still a real doctor since Melissa introduced me as a physician. One afternoon a week I'll be at the Eric B. Chandler Clinic this afternoon doing God's work at a federally qualified health center with the residents, 10 Medicaid, undocumented, insured persons, and also ran rounds at Medicine Princeton Health, did a bunch of work in the biopharma arena before coming to Horizon. So also have a perspective on kind of where the pharmaceutical industry juxtaposed all the things that we're talking about. We're doing a lot of work in the areas that Melissa touched on: health, social determinants, data integration, our core work, and population health. So I think I'm turning it up to Lucy.
Good morning. I'm Lucy Talheimer. I'm the Chief Strategy and Impact Officer with Meals on Wheels America. I have been with Meals on Wheels America for the last 6 years, and prior to that, I spent many years in other national nonprofits that were focused on aging, health, and long-term care issues. Most of that time spent at AARP, very actively working on home and community-based services. So came to Meals on Wheels America, which is a national leadership and membership organization that is supporting and enabling the thousands of local community-based Meals on Wheels providers to serve seniors in need, right? Our mission and our vision is that no senior goes hungry or isolated in this country. For most of you who don't know, Meals on Wheels services, of course, deliver meals, but they deliver so much more than that. And I think we'll come back and talk a little bit more about the full value proposition that Meals on Wheels can bring to the table, and to actually partnering with our clinical folks like Steve here. So Emily, I'll turn it over to you for an initial intro, and then we can come back around.
Great, thank you, and good morning, everyone. My name is Emily Mortimer. I'm the Senior Director for Healthcare Strategy here at LexisNexis, and I'm responsible for our strategy as it relates to our social determinants of health data. If you're familiar with LexisNexis, it might be with a little bit more of an eye toward how we, support referential data. In particular, I first was introduced to LexisNexis in college, searching it as a database of legal documents. But the work we do in healthcare really does span a lot of areas that are relevant to the whole person conversation today. Some of those include, being a part of the validation process for prescribers and prescription verification. That really makes the process for a patient much smoother, much more real time. But also, in the social determinants, health and identity space, we work on verification and authentication that helps to connect your health records. If you consider EHR and EMR systems and your access to those portals via MyChart, a lot of the authentication process is really driven by referential data. So LexisNexis plays in, the process of the whole person care spectrum very clearly. Then just the last note is sort of in the social determinants of health space, which is, I think, particularly important and impactful to the conversation today. We're really working to provide a broad spectrum view of a person's experience outside of the clinical encounter to help really collaborate and emphasize the other things that are happening in an individual's life that can impact their health. So thanks, Melissa. I'll turn it back to you.
Awesome. Thanks, friends. So now that you know our panel participants, let me share one moment of housekeeping, and then we're going to jump right in with Q&A. So from a housekeeping perspective, our goal in this next 30 minutes, 35 minutes, is to let you guys who are the attendees ask our panelists as many questions as are top of mind for you. So while I've got a bunch of questions teed up in case we've got a silent audience, I'm going to be watching the panel chat on the right-hand side of my screen very carefully. So to our attendees, if you've got a question for our group, any one person or everyone, pop it in the chat or pop it in the Q&A bar. I'm going to ask your questions real time while also filling the time with the questions that we've pre-prepared in the event that we don't have questions. So ask away. Our goal is to answer as many of your questions as possible and let our planned questions be secondary to yours. Okay, so with that little bit of housekeeping, let's jump right in a little bit, right? So we talked at the opening, we're here talking about two themes, whole person care and breaking down silos. When I look around this room, we've got really a community support partner, a health plan partner, and a data guru sitting on the call. Each of you has a different lens or a different context of approaching whole person care and solving this silo busting problem. Maybe each of you could share a little bit about your organization's lens or context on approaching whole person care. How are you breaking down the silos that are so real that each of us faces today? So Steve, we started with you. Let's start with you, since you're in the hub as the insurer. You're the one who collects the funding and makes the payments to everybody else around the table. So maybe we'll start with you, and then we'll head around Lucy and Emily.
Thanks so much, Melissa. So our approach over the last 12 years or so has been move from volume to value, the move from being the payer that was beating down clinicians on rates and doing a lot of utilization management. We still do some of that, but really the transformation has been around whole person health to bring together the payment incentives. So again, value versus volume, to bring knowledge, information, point of care, and a lot of things there with our healthcare platform enabled by Health Cloud, of course, Health Cloud, and a bunch of other technologies, and the social determinants area with NowPal, and really looking at working collaboratively. So the big change and what actually affected me to Horizon about a decade ago was working collaboratively with partners, whether a solo family physician or he be advanced practice nurse or community health workers doing in our social determinants work, or with physical therapists, occupational therapists, which happens to be my profession. So that really that kind of collaboration, which is certainly helped and supported and enabled by technology and data science and machine learning and all that fancy stuff. But it really gets down to kind of a human interaction and human motivation that brings the person or patient, she, he, they, into the center of the equation to achieve whole person health, including, again, behavioral health, as well as things that are social drivers, as well as kind of the blocking and tackling around diabetes and heart failure and COPD and asthma, psoriasis and kind of meaning and substance use disorder and all the other components of, as well as really focusing on health and wellness as opposed to just, and I just mentioned a bunch of clinical conditions, which physicians tend to do, but focusing on prevention and wellness and health promotion in that whole person.
You're on mute.
We would have learned this by now. Clearly, I'm still learning how to deal with COVID. That's so funny. You know, Steve, as I listen to you from a physician's perspective, you're right. We listen to the clinical conditions. That's where our mind tends to go first when we're thinking healthcare. But Lucy, from your perspective, you see the folks for whom it's simply too far of a reach to deal with clinical conditions because we've got folks that are simply hungry and without food. Tell us a little bit about your lens of standing in the gap from a healthcare perspective, more so than just a social support perspective.
So Meals on Wheels programs have been in the social determinants business for decades, right? So they are the bridge oftentimes between the acute and the clinical, and an individual's ability to stay safe and independent at home. So increasingly, the population, of course, is older, multiple medications, multiple chronic conditions, limitations in their activities of daily living, a pretty vulnerable, frail population. So there's already a health need present there, and what we're always trying to do is avert a more serious episode that could result in their actually having to leave their home, which they don't want to do. Many of these folks don't have any kind of support system available to them. So Meals on Wheels delivers not just the nutrition services, and of course nutrition services tailored to their chronic conditions. So, you know, we have to be able to provide medically appropriate meals. But we also provide that critical human contact, which we've learned so much about in the last year in terms of the negative consequences on health. We make sure their environment is safe and free of fall hazards. Falls, as I'm sure Steve would say, becomes a major trigger for a whole series of acute and costly episodes. And we look at them holistically and see what other needs they might have and connect them to other community services as needed. And they become the eyes and ears on an ongoing basis. Unique to Meals on Wheels is they have the trust and they are crossing the threshold. So these individuals day in, day out. How are they changing? How does their mental state appear, right? Are they dressed and clean, or are they coming, disoriented or looking like they're not sure what's happening? Is the home environment, also clean and in good repair? All those things together make up the ability for someone to stay healthy and safe in their homes. And I think that's what Meals on Wheels brings to the table. And increasingly, we're working hard to build that bridge between the clinical and that individual so that we can continue to share those insights that we glean on a daily basis.
That's super helpful. You know, Lucy, you touched on data, obviously, data. Everywhere I go these days, inside plans, at conferences, just going around and networking, the story of the year is data. How to get it, how to use it. Emily, from your standpoint, you're in an interesting role because just like you mentioned, a lot of folks hear the term LexisNexis, they assume old school legal searches, and they don't quite know what value to expect out of data from the standpoint of the caring for the whole person and standing in the gap to break down silos. Fill us in a little bit. Tell us about your real value proposition of what's the real practical data story up underneath your lens on whole person care.
Yeah, absolutely. Thank you, Melissa. So I think, we talk a lot in healthcare about the different silos, and I think we often consider the kind of impact of separation of payers and providers, and those are real silos that have a major impact on patient care. But even within some of those structures, there are silos that separate workflows and create kind of gaps where data that might be available isn't being shared in ways that are kind of meaningful and impactful. Or you can consider, the silos of data that exist. So in particular, in the space of social determinants of health, a lot of health systems and payers, they work to survey their populations and their members. They want to understand what's at risk, what they're at risk for, and what factors are impacting their health. And all of that is, a laudable effort, and it needs to continue. But it often winds up with a view of a patient that either is limited to that point in time at which the survey was completed. It could be vulnerable to bias if a patient is unwilling to share a certain type of risk, depending on how the survey is administered, or whether their perspective is that, someone's going to pass judgment or make a decision that they're uncomfortable with. So knowing all of that and being as in tune to those kind of separations that exist between the different populations of patients and providers and payers, I think it can be helpful to consider, a data element that provides a whole picture and that is maybe not as vulnerable to those biases or to those, stagnation of data. So on that perspective, LexisNexis is able to leverage our really industry-leading set of data around a consumer or an identity. So being able to link accurately over a long period of time and with a high level of precision, all of the records that tie Emily Mortimer together throughout the lifespan. I'm Emily Mortimer. I live in Minnesota today, but not that long ago, I lived in Pennsylvania. And not that long before that, my name was Emily Hofer. And if you want to understand everything about me, we're trying to, see a view that's going to be vulnerable to those pieces that are separated over time. And LexisNexis can really bring all of that together and then layer on top of that a set of clinically validated attributes that are tied to clinical outcomes. Many of them adhere to the large pillars of social determinants that we're all familiar with, thinking about housing, thinking about safety, thinking about the social network and social isolation, and being able to provide all of that at one time to update it frequently will provide kind of a more robust view for the systems and the payers that are looking to assess social determinants. So we really work a lot with health systems and with payers to figure out how to integrate that data into their workflow so that it also doesn't create more silos. The analytics team has access to data, but you need to take it to the care management level, make sure it's having an impact on your patients and on your management of that population.
Okay, so Emily, I'm going to put you on the spot. So I'm always curious what the N of 1 data look like. Does the story of Emily Mortimer's data in your database look like you? Is it pretty reflective of your real N of 1 experience?
It is very reflective. It'll include things that, you might be surprised you have access to. So because, I lived with roommates and I would have some utilities in my name, they would have some in their name. LexisNexis can identify that connection. LexisNexis can also then use that to understand, well, what are your other potential resources, right? So if I have a roommate who is an adult without any child dependence, they might be able to help me get to the grocery store. They might be able to help me get to my doctor's appointment. That's a real resource that's going to be impactful to my care and to my ability to manage my own care. So making that connection is a really important part of understanding the social network around a patient.
Yeah, and I would just, and Melissa, you can do this as well. I know you're our moderator. So Emily was very kind enough to be revealing and share her name before I guess she got married. That's what I'm assuming. I don't want to make any misperceptions in the world, but let's talk about my mother. I'm not going to give you her name. She's 87. She's got some dementia. She's living at home with 3 caregivers. She says, "What? What are you saying? I can't hear you." She's real Southern. So, that speaks to a person who doesn't use an iPad, a laptop, a smartphone, can barely turn on the TV. And so in this constellation of really cool whiz bang and data science, you get down to people who have far basic, profoundly simple. And no disrespect to my mother, but she is quite simple these days. She is back in junior high school.
Yeah, Steve, you're exactly right. I mean, you've almost actually pitched the right question to Lucy. Lucy, Lucy and I, in full transparency, Lucy and I worked together for years on the value of Meals on Wheels and your functionalities in the healthcare space. I mean, you guys are really in a unique position with your ability to cross the threshold and see Steve's mom daily, face to face, and understand the days that are good, the days that are not so good, the days she's clean, the days she's not, the days she needs a little more help. Tell us a little bit more about the value of having a human being able to cross the threshold. Meals on Wheels, community health workers, personal care assistants, lots of folks. But tell us a little bit about what data you can collect and how you actually get that back into Steve's hands as a physician so Steve can action it and support it from his role as the caring physician.
Right. That's great. And Steve, you're so right. We have lots of folks who come to us with a great technology idea for how they're going to solve some of these issues for vulnerable homebound seniors. And there's just one little problem, right? Most of those seniors aren't really interested or in wanting to use that kind of technology or have the ability to do it or have enough of the support system to do it. So yes, Meals on Wheels, because it is a very much of a trusted, recognized, community partner, right? People know who Meals on Wheels is and they welcome them into their homes. So they do collect a certain amount. We're doing several projects with different healthcare partners where we collect some initial information. Of course, when a referral comes to a Meals on Wheels program, they get intake information. They even collect information like around how many times they've been to the emergency room lately, how many times they were admitted to the hospital, are there any planned hospitalizations, what meds are they on, are they using any kind of medical equipment, do they need help with activities of daily living? That's even before they enter the home. In one project that we're doing, which I think is a pretty formalized way of leveraging Meals on Wheels for data collection, is on a daily basis, the Meals on Wheels delivery person just sort of, they want to keep that trusting relationship. So just get a sense of how are you feeling today, right? Are you having any kind of pain? But then on a weekly basis, they're asking some more specific questions. Have you been able to take your meds every day? Do you have everything you need? How's your appetite been? Have you been sleeping well? Have you had any falls this week? And then in addition to that, they're doing some observational data collection, if you will. So how does the home look? How does the individual look, right? Are they clean? Are they dressed appropriately? How does their mental state seem? Do we detect any changes in their mental state or mood? And what they do is they collect all that information. They actually, in this case, are reporting it back to care managers with a health plan on a weekly basis. There's agreement up front about what kinds of things are going to trigger an immediate escalation to a care manager. So a fall is one of them, right? That's something where the care manager then will follow back up with the individual. Meals on Wheels doesn't necessarily wait for care managers to do that, because if somebody needs something, they're going to make sure that that person gets connected to their PCP or the service. But then also the care managers using it to make some decisions about the duration of the Meals on Wheels service that they'll offer. So the initial benefit is 4 weeks. They might decide that this person maybe could benefit from another 4 or 8 weeks. So they use that information to sort of keep tabs. It becomes an extension of the care management team, essentially. So that's one example of how we can collect a whole lot of real-time data and get that back to decision makers quickly. In another project that we're doing, Steve, we send monthly reports to the PCP, even if nothing has happened, just to keep them up to speed on what's going on with their patient. So there's different ways we can do this.
Awesome. So I want to follow the data for a second. Emily, I'm going to ask you second. I want to ask Steve as a physician a question, and then I want to bring it back to you too. So I've got a rabbit hole we're going to go down. So Steve, when I imagine Lucy and her folks out in the field collecting this data, it's pretty easy for us to envision how to get the data in the hands of you as a payer. But if you put your treating provider hat on, your actual physician hat in the exam room, how do we get these observations, the data elements around these real world, real life observations into the right hands of the clinician directing the care, coordinating the care, and ultimately helping the patient take the next step? How do you guys do that at Horizon? How do you make that happen? And then Emily, I'm coming to you next with a data question, next step.
Yeah, so we often don't. That's the sad short answer. We are enveloping or looking to bring in harmonize SDOH behavioral into the moment of truth for that primary care physician who he or he is on the proverbial hamster wheel trying to see somewhere, I don't know, rough justice, 22 and 32 patients a day. If you're a pediatrician, it's more like 50 during the cough, cold, flu season, though COVID attenuated that to tell. So it's not an easy thing to do. We do recognize the value, and that's where our technology insights and again related to my mother, she's not going to be able to appreciate or understand or use a smartphone or use an app or use a widget or whatever, but the doctors tending to her can incorporate that information, whether it be from LexisNexis or now PAL or Epic or what have you. So that's what we're endeavoring to do, creating data repositories, what we call a single source of truth, longitudinal patient record that brings in ultimately things from wearables, though we're not doing that very much right now, in all honesty. Information from EMRs, which we're doing a lot, information from community health workers, which we're doing to a variable extent, or folks like Lucy and Meals on Wheels from those, and then the last thing I'll say is some medical groups, health systems have this organized a bit better. One group that I work with has a very strong homebound person program with advanced practice nurses and a geriatrician overseeing it and some MAs and using even algorithms around because New Jersey has unfortunately, a lot of something called traffic, which is a real world problem, or first world problem. Actually, it's a third world problem as well. So in any event, those are some of the kind of things we're doing to address that, bringing the information to the primary care clinician.
That's super helpful. So Emily, we've got a great question from the audience, and we've got a few more from the audience coming in as well. You know, Emily, that's the perfect segue to asking a little bit from y'all's perspective as a really big high-end provider of big data and N-of-1 data. How do you find the data? How do you pull the data? What's the source? Is it all publicly available records? Is it provider-driven extracts? Is it payer integration of longitudinal record or gathering from folks like Meals on Wheels? Just to help us understand a little bit, or our audience understand the art of the real world, because you guys are kind of best in breed from a data perspective. Where do you get it all to develop the N-of-1 views at the person level?
Yeah, absolutely. And thank you. I think that was Wendy's question in the chat. Thank you for bringing that forward, Wendy. I think the point that I didn't make clearly enough is that the data we're talking about related to the LexisNexis social determinants of health view is really all outside of the clinical experience. So it is public records, but it's also some proprietary and government source data, data from things like credit bureaus, data that's been aggregated together to create a comprehensive view of virtually all adults in the United States, with longitudinality in place around the public records data that's available on you. So your clinical data is not integrated into that solution at this point. I mentioned that we use clinically validated attributes from that consumer data. And what I mean by that is, I'm going to throw a number out that I don't even know if it's correct, but let's say we have 1,000 different data points on a person. We went through a process to understand in a statistical model which of those data points were predictive of a health-related outcome. And not every single one is. So one of the things that we've worked on very kind of closely in conjunction with folks at EHI is to determine sort of what do we think the real kind of ethical use of the data should be. And one of those proponents is, we don't want to give anything more than is relevant to the health experience of a patient. So like I said, we have 1,000 attributes, but what we're going to provide are the ones that are correlated with actual clinical and health outcomes. So that's what I meant when I said that they were kind of clinically validated. So the data itself, you can imagine, is coming from various records. You're talking about things that are filed with the government, things that are publicly available, things like driver's licenses. So all kinds of different data sources there. And then one thing I wanted to tie back to what Lucy said earlier around Meals on Wheels and their ability to not only be a point of gathering additional data, but one of the things you mentioned really, my mind, a big problem that we have with social determinants of health in the industry broadly today, which is a feedback loop, right? So you mentioned you might get a patient who's assigned to 4 weeks of Meals on Wheels benefits. So through various processes earlier in the pipeline, the industry has done a pretty good job of saying, who do we think is at risk and who might benefit from these resources? You can do that based at the point of care. You can do that based on looking at LexisNexis social determinants and getting a risk profile. But then to figure out, has the patient really exacted enough benefit from this? Do they need to continue on that program? Requires the feedback loop. It requires the provider of that service to be able to provide that data back. And I'm really heartened to hear how you guys are working on that, because I think it is, Meals on Wheels is doing it, and that's incredibly impactful. But throughout the different types of social services available, one thing that we all in the industry care about is figuring out, how do we make that feedback mechanism a little bit more standardized and kind of solution oriented, so that we can figure out where additional benefits and resources are needed. So thanks.
This is so great to see everybody connecting the dots. Steve, I know you guys have done some great work in the innovation space at Horizon over the last couple of years. When I think about what Lucy's describing and Emily's describing, this use of data, you guys often sit as the hub of coordinating the cadence and the sequence of interventions across these patients who need more than they're able to get. Maybe you can tell our audience just a little bit about your approach to SmartMatch and sort of how you're actually making this happen in the real world.
Yeah, so SmartMatch is a particular application in behavioral health. So we work, and I don't have any financial interest. They're a vendor, so I'll use the name. They're called Quartet. They work with some other national payers and others. So we invite and ask our primary care or multi-specialty groups if they want to participate. They certainly don't have to, but most do. And then that technology that was developed by Quartet uses algorithms, machine learning, data science, if you will, to identify persons who may or likely have high probability of having substance use disorder, bipolar, generalized anxiety disorder, major depressive disorder, and so that is a tool that we use, again, to identify people who may have something that she or he has multiple ER visits and has not been appropriately or correctly diagnosed by his or her family physician, general internist, pediatrician, and that's been good. I mean, the feedback has been positive, not perfect. Some clinicians say, "Oh well, this SmartMatch algorithm didn't work." So again, it's progress, not perfection, and it has again led to people then being appropriately referred to a behavioral health clinician, whether a psychiatrist, psychologist, family counselor, masters in social work, that sort of thing.
Yeah, so Steve, just talking real world whole person care, if the pandemic has taught us one thing, like Lucy said, it's loneliness, it's the impact of loneliness, and it's the impact on mental health. When you run across folks that your data shows you probably have some sort of substance abuse disorder, probably have some sort of mental health condition, anxiety, bipolar, schizophrenia, whatever, what's the biggest challenge you run into in making the next step of progress? Is it the double HIPAA secret? Is it capacity of providers, engagement?
There may be some level of denial. So the person is offended, quickly responding to the primary care doctor. I can't believe you're asking this question. So there's that issue, and that certainly is well known, and the notion of recognizing that you have a problem in the 12-step program. So there's that aspect of it. The connecting the person to a counselor or behavioral health clinician, another step that we've tried to tighten up, improve, and that's part of the workflow in this identifying people with unidentified problems. And so again, it's progress, not perfection. It's certainly something that still has areas, opportunities for improvement. There again, in kind of Lucy's world, there may be some significant social determinants overlays as well: transportation, health literacy, implicit bias, which is another issue that can come into play.
Yeah, Lucy, you chime in, and then I want to ask you a detailed question along this line too.
I was just going to say that it's particular, 1 in 4 Meals on Wheels clients, homebound seniors, live alone, right? And so depression is a huge issue. And of course, once you're depressed, you're not likely to eat and stay appropriately nourished. And, it's just a vicious cycle. So many Meals on Wheels programs, in addition to just the regular human contact that they offer when they deliver their meals, many of them even kept trying to do it from a physically distant way daily during COVID. They offer a whole host of different kinds of social engagement kinds of programming, some online, some by telephone, some in person, really trying to keep people connected. It's so important. So I just wanted to jump in there and just say there are ways to even get to people who seem like they're so isolated and removed from the normal stream of people who are seen in clinical settings.
Yep. So I'm going to brag on Emily and the LexisNexis data and lots of her colleagues and competitors in the data space. We're really good, like Steve said, we're really good at hotspotting a person and their likely challenges. Steve, I really appreciate that you bring in that a lot of folks, sometimes the biggest barrier is personal admission or comfort admitting that you have an issue that needs attention, such as a behavioral and mental health problem. Lucy, we hear this in the food insecurity world all the time. We work with plans. We know for sure we have a person who has no food in the pantry, but getting them to let us know that they are hungry and don't have food in the pantry and no way to get food, and then helping them get connected. Tell us a little bit, just as a good example, every social support program has a way of getting qualified and eligible for benefits. How would that even happen if the N of 1 data coming out of LexisNexis says we have a person who's hungry, the clinician confirms it? How do you even go about helping a person who you think is food insecure from the data qualify for Meals on Wheels services, get meals? And so what does it feel like real world?
Right. Well, real world, there's different ways that people get connected to Meals on Wheels because either they or somebody thinks that they might benefit from services. I mean, sometimes somebody's coming out of a hospital, right? So that's an immediate, obvious, someone needs help for some period of time on a post-discharge basis. But Meals on Wheels programs typically get a lot of referrals from family members, caregivers, somebody who lives states away and is worried about their mom, or their granddad, and would love for somebody to deliver meals. They get referrals from aging network service providers. Rarely, I think, not as much docs. I mean, one of our dreams would be that a physician could just write a prescription for Meals on Wheels and it would be covered, right? Meals on Wheels generally, they don't make distinction on who's eligible to receive services based on income. If the program is using funds from through the Older Americans Act, which is the federal authorizing legislation that brings some federal dollars to local programs, however, that only pays for about 1/3 of Meals on Wheels services provided. Someone's supposed to be over 60, generally homebound, to receive those services. But they raise money philanthropically, they get money from other sources, and they have ways of trying to serve anybody who's who's in need. And then they help them try to qualify for SNAP benefits or anything like that they may be eligible for. But it's tough. It's really tough. There is no cohesive, safety net, if you will, that ensures that someone who might benefit from need gets service. There are now standard questions that often get asked to gauge whether or not someone meets the definition of food insecure, the national questions of how often were you hungry in the last, did you food stretch, right? How often were you hungry in the last month, the last week? Did you have enough food to last the month? Those kinds of things. There are screener questions, and many health payers are using those screener questions to assess for food insecurity. But that doesn't necessarily mean that someone's going to accept service either. There's a strong, not everybody, they look at it as charity. They don't want to take charity, right? So,
yes. Well, I hate to cut us off. I will tell you all, I have appreciated spending the last few minutes with all of you. I could ask you, each of you, questions all day long and probably not run out. I know our audience could too. I thank you all for your time. To our attendees, I hope you enjoy the next 2 days of activities, and we look forward to learning a lot together in the next couple of days. And thank you all for your contributions and sharing such important information. Thank you, guys.
Thank you.
Thanks, Melissa. Bye-bye.